Thank you for joining us, everyone. And hello, everyone. Welcome to TP recap session. And today, Jillian, Hans, and Shreya will do a recap of the cases from last month. And very excited for their presentations. And let's get started. Would you guys like to unmute and introduce yourselves before we get started with your presentations?
Sure. Hi, I'm Jillian. I'm a medical student at Mount Sinai in New York. Excited to be with everybody.
Hi, I'm Shreya Upadhyay. I'm a medical graduate from Nepal. I'm really excited for this session today.
My name is Hans, and I'm a medical graduate as well. And yes, excited to learn from the others. So let's start.
And maybe you can start sharing the screen and share your presentation with us.
Okay, then I'll start sharing. Okay, can you see my presentation?
Yes, we can.
Okay, and my case would be the one from December 4th. Just a second. And the case presenter was Dr. Ravi, and the case discussants were Dr. Ravi and Dr. Sharia. And just a second, something is, why doesn't it? There are people coming in. So we have a 38-year-old male patient, and he presented with altered mental status and shortness of breath for 2 days. So we have a hyperacute situation with altered mental status and shortness of breath. The history of present illness was very easy because the patient was confused upon awakening. He was hypoxic, and his blood glucose was 300 milligram per deciliter. So the first questions that we ask ourselves is, why is the patient confused? And why is the patient hypoxic? Maybe anybody has an idea what could be going on at this stage. So the reflection that I have at this stage is, for altered mental status, we have our missed mnemonic, and that is metabolic, infection, structural, and toxins. So what could be metabolically wrong with this patient? Is it related to diabetes, which he was later found to have? Is it an infection or an ischemia in the brain? Does he have a structural problem? But that is usually something which develops over a longer period of time, not acutely. Or was he exposed to toxins? One possibility of a toxin would be an opioid. And of course, we also checked the sugar, but his sugar was fine. If available, we have a CT scanner to rule out other reasons, such as ischemia and most of all space occupying masses, or did the patient develop an acidosis? But most of all, we had the question, we have shortness of breath and altered mental status. What came first, or are these two different disease states? Now, if the patient developed shortness of breath first and then altered mental status, this seems rather unlikely. In our discussion, we mentioned that O2 extraction for the cells is still efficient even at a low SO2 of 70 to 80, and that is known as the Bohr effect. So the past medical history of our case was rheumatoid arthritis with hypertension, diabetes, and chronic kidney disease. And the patient had in his past a sarcoidosis. The medication is on prednisone, tocilizumab, an IL-2 inhibitor, and methotrexate. So the patient at this stage, we know he's immunocompromised for two reasons. First of all, his medication and his chronic disease, the diabetes as well as chronic kidney disease. in his physical examination was basically normal, except for a fever, a normal or low normal blood pressure, and a respiration of 22, which is still within normal, also tachypnic, and an SO2 of 80%. So at this stage, knowing that he's in the ED with an SO2 of 80%, what would you do immediately? And the answer there would be we would give the patient a nasal cannula and make sure that the patient gets an SO2 in the range of 90. Now, because of the altered mental status, we might also consider the possibility that the patient isn't able to secure his airways. So intubation is on the background of our consideration. The general was fine. The lung exam was the only abnormality. There we had rhonchi in the right lower middle lobe. Abdomen, diffuse tenderness, but otherwise normal. The CBC was basically normal, except of a low anemia of a low HB and a normal platelet, but at the lower line. The chemistry was normal with a slightly elevated potassium indicating kidney disease, and his creatinine was 3.80, which was his baseline. So he has chronic kidney disease in all likelihood. The glucose was 304, which is high. A1C, his diabetes is still not very well controlled, and a lactate of 7.4 with a low bicarb indicating possibly an anion gap acidosis, possibly from hypoxemia. So the differential that we are looking at is we have a lactic acidosis. Is it hypoperfusion and or impaired renal clearance? The differential at this stage would be a septic shock, and that can cause AMS. It could also be heart failure, but we haven't seen anything in our exam. So maybe an echo will show us a little bit more, and maybe an endocarditis, septic shock might be a possibility to explain the AMS. So we did an imaging, and there the chest X-ray showed right diaphragm pushed up and an opacity in the right middle lung. So there is some lung disease. The CT chest was a closer look, showed cavitary lesions. And what do you associate with cavitary lesions? Then we had an echo, which was basically normal with a normal, although somewhat low ejection fraction. The CT brain was unremarkable, but an MRI brain done showed a focus of DWI, that is signs of ischemia or stroke in the right superior cerebellum. So our differential at this point would be we have cell death by ischemia in the lung. These are the cavitary lesions. Do we have a pulmonary embolism to explain the cavitary lesions? Do we have an acute infection, maybe even sepsis with an abscess? A septic endocarditis would explain everything, but our echo didn't point in this direction. Does the patient have an underlying cancer, but our CD, abdomen, and chest didn't show anything so far? And he has a cerebellar stroke, which we need to explain. So our problem representation can be summarized. We have cavitary lung lesions, necrosis, and a cerebellar stroke. What could it be? I thought before we're looking at the final test, which might give us the clue for the diagnosis, let us look at a second case. And that was a case from Dr. Lara Lau, and the case discussant was Dr. Rabi. And I think we learn a lot from this as well. And I owe this case to Lyra, who mentioned it. And that is a 52-year-old female, and she presents with an abdominal pain, abdominal distension, acute kidney injury was suspected in the ED, and that was concerning for decompensated liver cirrhosis. Her past medical history was hepatitis B and D, She had liver cirrhosis. She was status post-liver transplant, and her medication was in many ways similar to our first patient. That is, her medication makes her immunocompromised, and she has diabetes, which again is a source of immunocompromising. So quick recap, what is hepatitis B and D? The two occur together, usually hepatitis B coming first and hepatitis B being a sub-infection. It can be incurred through maternal fetal transmission. I think with the babies being vaccinated for hepatitis B, this is very rare. Injection drug use is the main cause in our society, and blood transfusion was of importance in the past. The liver cirrhosis has, as mentioned before, a far-ranging consequence. The patient is immunocompromised, and the patient can, and usually if it is decompensated, does develop confusion from hepatic encephalopathy and a high ammonium. So here we would have AMS and liver failure. What can cause a decompensated liver? Just to mention a few points of this schemata, it is hepatic cellular cancer, then a progression of an underlying disease. Patient has hepatitis B or some other disease that affects the liver, and it manifests with ascites, with encephalopathy, and we have other causes that I just mentioned. What we can observe is a portal hypertension to the extent of hepatorenal syndrome. The physical exam of our second patient showed jaundice, abdominal distension, but also a fever. So like the first patient, we have a fever. The blood pressure is normal, SO2 is normal, heart and lung are unremarkable. The extremities showed mild pitting edema. And while the patient was in the hospital, she developed, quite surprisingly, a nodular painful rash. And I want to show the rash. That was this one, and she described it as painful, and it appeared in the hospital. The labs, before we go towards a differential, are pretty much normal, and as expected with liver cirrhosis and the possibility of ascites, we have a somewhat low hemoglobin, 9.8, so mild anemia, and a normal but low platelet. Chemistry is normal, liver function test normal, ALK-Phos was somewhat elevated, and everything else was her baseline, although elevated. Albumin reduced because of cirrhosis, INR 1.6, however, baseline, and her creatinine 1.57 is elevated, but it is her baseline. So we do not have acute kidney injury as presumed at the beginning. It looks more like a chronic kidney injury or chronic kidney disease. Urine analysis was within normal limit. Her virology was completely normal, and her hepatitis B viral load was completely suppressed. So now we have possibly a decompensated liver cirrhosis, or do we not have a liver cirrhosis? Let's look at liver cirrhosis. It usually presents with ascites and edema. The liver is fibrosed. It causes portal hypertension as the general feature. Liver dysfunction increases the bilirubin and the INR, but she is baseline. Fever is unusual because patients, when they have liver cirrhosis, are immunocompromised. Even in the case of spontaneous bacterial peritonitis, we rarely see a fever. And we have an immunocompromised patient with fever. There must be something going on. We have an abdominal pain in the patient, which is unusual for decompensated liver cirrhosis. And liver dysfunction with and without the infection usually presents with AMS from hepatic encephalopathy. She doesn't have this. Asterixis wasn't shown, and she didn't have an elevated ammonia. So what would be our problem presentation now, refined from the chief complaint? 52-year-old female. She presents with abdominal pain. We have distension. We have chronic kidney disease. We have a fever, and we have normal CBC and normal liver function tests. Albumin, INR, and CR at baseline, and no signs of hepatic encephalopathy. What additional tests would you suggest? Just to anticipate the answers, we did a few further tests were done. One of them was imaging, CT, chest, and abdomen, completely normal. In particular, we had no signs of hepatocellular carcinoma. Hepatitis B, as mentioned before, is completely controlled. No portal thrombosis was seen. No evidence for varices or GI bleeds. Virology all negative. However, the blood culture grew yeast. And now we have the question, we have an immunocompromised patient with chronic liver disease, chronic kidney disease, and a positive blood culture for yeast. What kind of yeast are growing in the blood culture? Now, the yeast that we might consider in our differential are Candida, Cryptococcus, Fusarium, and then our endemic fungi, and PJP, but the latter, the PJP, doesn't grow in culture. If the patient came from California, southern part of California in the desert, we would have to consider coccidiomycosis, but coccidiomycosis doesn't grow in blood culture, and if so, extremely rarely. So it's Candida, Cryptococcus, and Fusarium, if we have a culture. The febrile painful nodular rash in a patient with cirrhosis and positive blood culture for yeast. That is basically our problem representation here. Fusarium affects mainly neutropenic patients. Our patient is not neutropenic. Candida rarely causes paniculitis, so possibly it's not Candida either. Cryptococcus is seen in patients with cirrhosis and in patients with HIV, so that is a good candidate, and we should keep it in mind. Hepatitis B causes a rash as well, the polyarteritis nodosa, but it doesn't grow in a blood culture, so we don't need to consider it. In the past, patient has sarcoidosis, so that could be a reason for her rash, sarcoidosis, and the fungi that I just mentioned, the endemic ones, as well as coccidiomycosis, which is unlikely because of the blood culture. So crypto is our main consideration. So we did blood culture, we did a test for crypto, and the Cryptococcus antigen test was negative. What went wrong here? This was a case where I've learned that we need to consider the phenomenon of the proso, or the prozone phenomenon. That is, if the patient has fulminant cryptococcal infection and the immune system mounted an immense defense mechanism with lots of antibodies, these antibodies prevent coagulation of the antigen-antibody complex. Therefore, we cannot see a positive CRAG result. We need to dilute the serum, and that is exactly what was done. The patient's lumbar puncture was diluted, and it was found positive for Cryptococcus. This case has at least taught me that we can see Cryptococcus in two ways. We can see it as a rash and in the form of an infection. Cryptococcus, I know, likes to migrate to the brain. It is the Trojan horse effect, which I will mention later on because it's intracellular and causes meningitis. But this meningitis is so insidious that it takes a long time to develop. Patients usually show unspecific symptoms like headache. This patient wasn't at that stage. She had something else. Our first patient can now be revisited, and the final test was a lumbar puncture, and there again, the CRAG test was positive. And that was then the final diagnosis, both immunocompromised, both with cryptococcal infection, the first one with a severe meningocryptococcal infection. Quickly, the pathology of case 1, and then I'm done. Cryptococcus infection occurs to the lungs. And usually an immunocompromised patient doesn't notice anything. The macrophages internalize the bug and it lives there until the patient becomes immunocompromised. The high affinity of this bug for the CNS causes CNS meningoencephalitis with inflammation and formation locally of thrombi. And this causes in turn ischemia and infarction of the fine blood vessels supplying underlying structures. And in our first case, it was a superior cerebellum. And this explains the cavitary lung lesions from a primary infection with necrosis and right superior DWI finding suspicious of a stroke. And just as a quick summary of Cryptococcus, it's an encapsulated yeast with a polysaccharide capsule. It is found commonly in the environment. Infection occurs through inhalation. It is a facultative intracellular organism. That is, its initial infection is asymptomatic. It is contained in macrophages. These macrophages migrate into the brain, get in there, and in an immunocompromised patient, it causes infection. And the treatment, very quickly, in an immunocompetent patient, pretty easy. The patient receives fluconazole for a year. For an immunocompromised patient, we do it in 2 stages with an induction therapy and a maintenance therapy with fluconazole. I hope I didn't talk too long, but I want to say many thanks to everybody.
Thank you, Hans, for such a wonderful presentation and for covering not only 1 case, but 2 cases for us and just teaching us how to separate different fungal infections. It was a wonderful presentation. And we have Jillian going next, and very excited for your presentation, Jillian.
Okay, so today, here, I'll put this in slideshow form. So today I'm going to be going over some learning points from a case presented on December 22nd by Julia and presented to Kirtan and Austin. So the case was a 30-year-old male with Fontan physiology, so a history of the Fontan procedure, who presents with acute confusion and was found to have hyperammonemia. So just before we go into some of the teaching from this case, it's good to have a little bit of a review of Fontan physiology. So on the left is for reference the normal circulation in a normal heart versus in the Fontan heart. So in Fontan physiology, the blood basically bypasses the entire bypasses the heart, and that there's a slight connection between the right atrium and the venous system, but basically flow to the lungs is done through passive, which leads to very high venous pressures. And usually this is done because there's some problem with the left heart, congenital problem. So blood is diverted from the left side of the heart, the left atrium, to both the right atrium and the right ventricle, and then the right side of the heart pumps blood systemically. And so as you can imagine, this procedure is very helpful for people who can't pump oxygenated blood out of the body, but it also has a lot of complications. And one of those is Fontan-associated liver disease. And the disease is primarily due to congestion, chronic venous congestion from elevated pressures. And these high pressures can mimic hepatic venous outflow, obstruction, because instead of having a block actually at the hepatic vein, you just have super high pressures, which prevents flow through the liver. And that results in decreased oxygen delivery, damage to hepatocytes, and can eventually lead to cirrhosis. Okay, let's go back to our patient though. So when we see the labs, we see that the patient has a platelets of 146, an AST of 43, ALT of 41, bilirubin of 1.8, so slightly elevated, and a normal albumin. Oh, and the INR should be 1.3. I forgot to change that. So the INR is relatively normal, but the ammonia is 138. And then the ultrasound shows a liver with mildly nodular surface and no ascites. And then in this aliquot, we also learned that the patient has a known history of Fontan-associated liver disease. So so the question I have is, does this patient's liver dysfunction seem proportional to the degree of encephalopathy? And I think what we can agree with is that, like, yes, this patient has some liver disease, but the synthetic function is not that bad. And so compared to the degree of encephalopathy, which is usually a late finding in cirrhosis, we see a relatively normal hepatic function. Okay, so let's now talk. We've confirmed that this patient has hyperammonemia. So what are the causes of hyperammonemia? And this is a very large schema, and the broad schema includes like excessive nitrogen load from intake or catabolism, inborn errors of metabolism or ammonia-producing organisms, and then liver dysfunction. But for now, since we have a patient with confirmed liver disease, we're going to focus on the two causes here that are related to liver disease. Okay, so if we think of the mechanisms of hepatic encephalopathy due to excess ammonia and then other toxins, but for now we're just going to simplify by talking about ammonia. We think that ammonia comes from the gut and then it goes through the portal circulation, portal vein, and there can be two reasons why the ammonia, eventually excess ammonia, gets to the brain and causes encephalopathy. One is that the liver itself, the ammonia can get to the liver fine through the portal circulation. However, the liver is not working well and can't actually clear that ammonia, and that happens in acute liver failure and cirrhosis. But even if the liver is working okay and can sort of clear the ammonia from the blood, if the ammonia is not able to get to the liver, then you can get, because of shunting, that's due to high pressures, then you end up with excess ammonia getting to the brain because the liver doesn't see it. And so that can be also caused by cirrhosis or any cause of elevated pressure, post-sinusoidal portal hypertension, pre-sinusoidal hypertension, congenital hepatic shunts that exist independent of any liver disease, just a shunt that exists even if the liver is working just fine, or iatrogenically when we do a TIPS procedure. Okay, so question is, which matters more for hepatic encephalopathy, the degree of fibrosis or whether portal blood is reaching hepatocytes? And I guess if anybody has any thoughts, I'd like to hear them. But I guess there's some evidence that the more important thing for encephalopathy is related to the amount of shunting that occurs. And this comes from a variety of clinical observations. So one is that when we do when we do a TIPS procedure, regardless of initial liver function, there's a 30 to 50% chance of encephalopathy. Additionally, in patients who have reduced portal flow before the TIPS procedure, so there's already limited flow through the portal veins. When you do the TIPS procedure, that reduced portal flow is actually protective against them, which suggests that like the decreased initial flow through that shunt is protecting them from the encephalopathy, even if their liver function is worse. And then also like imaging and interventional studies have shown that like there's a correlation between the size of the shunt and the degree of encephalopathy. Okay. Okay, so now back to our patient. So on the ultrasound, the patient was found to have splenomegaly and a large splenorenal shunt, which confirms the hypothesis that yes, this patient has liver disease, but maybe the encephalopathy is coming from this shunt. Okay, so why does this patient have a shunt? So in general, the portosystemic shunts happen to relieve portal venous hypertension by diverting the blood into a lower pressure veins, and it can happen for a variety of reasons that I outlined previously. But I guess another question that I have for you, so which one of these physiologies does Fontan physiology most likely fit? Okay, we can think about it. So it doesn't fit perfectly, but the Fontan physiology more fits the post-sinusoidal portal hypertension because the excess pressure on the outflow in the systemic venous system creates a barrier, basically a functional barrier to hepatic venous outflow. Okay. And so let's talk about whether the etiology of the shunting affects the likelihood of portosystemic shunt formation. So if we think about the three causes, like where you have pre-sinusoidal, sinusoidal, or post-sinusoidal portal hypertension, which one of these is most likely to form a shunt? It's not clear entirely, but there's some evidence that in pre-sinusoidal portal hypertension, because the liver is relatively low pressure, there's an option for shunts to form both backwards into systemic circulation, like a portosystemic shunt, and forward into a portal shunt. So patients with pre-sinusoidal portal hypertension, like portal vein thrombosis or schistosomiasis, are more likely to have portal collaterals that relatively spares them from, the large systemic shunt. So those usually develop a little bit later compared to sinusoidal and post-sinusoidal portal hypertension, where there's no option for the blood to flow forward, and so the shunts only form backwards. And there's some veno-venal shunts that can happen in post-sinusoidal portal hypertension. But those are relatively less because the pressure, especially in the case of like Fontan physiology, where the post liver pressures are much higher, those shunts are less likely to form than the backward shunts. Okay, so now what are the implications for management? So encephalopathy related to shunts compared to hepatocyte failure related encephalopathy. So the management is pretty similar. In both cases, lactulose and with or without rifaximin are used to manage the ammonia levels and sort of excrete it through the gut. But then the only difference is that in shunt-related encephalopathy, if there's not terrible cirrhosis or impossible to close the shunt, like if the shunt isn't essential for the blood to flow properly, then shunt embolization is an option. And then the only other caveat I'll mention is that in acute liver failure, there's slightly different management where lactulose and rifaximin don't have great clinical benefit. So continuous renal replacement therapy lowers ammonia even in the absence of AKI. Okay. So take-home points in patients with evidence of liver disease but underwhelming synthetic function impairment, I learned to look for possible hepatic encephalopathy. I learned to look for a shunt. And then in the etiology of portal hypertension matters for the likelihood of shunt formation and the timing of it in the course of the disease. And then Fontan physiology can have various impacts on the liver. It can cause frank cirrhosis over time due to damage to the liver, but it also can, through the pressure physiology, can cause large shunt formation. Okay, and references. Thank you.
Thank you, Julian, for covering such a complicated case for us, and loved all the illustrations you added, and really helped me fill my knowledge gaps about Fontaine procedure and shunts. So really loved the presentation. Shreya, would you like to go next?
Yes, just a second. I've just requested to let me share.
Yes, you can share now, Shreya.
Okay. Can you see it?
Yes, we can now.
Okay. Just a second. Yeah. So the topic of TP discussion today is I chose is scrub typhus case presented by myself on 12/24, discussions fair Yusuf and Kirtan. And the reason I chose this was the unfamiliarity of this disease in many of us. So I thought, why not learn this together? So a 19-year-old male presented with difficulty walking and pain in left hip and around inguinal region for 4 days. He actually had intermittent fever 2 weeks before, and later after which got better after antibiotics. And after 1 week, he started having difficulty bearing weight, and since 4 days, he was having severe left hip and inguinal pain. He had no rash, no urinary complaints, no genital oral lesions, and he has never been sexually active. He lives in hilly region of Nepal. He's a student, smokes one pack cigarette, and he doesn't drink alcohol. There was no past medical history, medications, or allergy history. Vitals were normal. All examinations were normal except MSK. Left hip held in externally rotated position with restricted movements and pain in the insertion site of iliopsoas on the lesser trochanter. The pertinent labs were neutrophilic predominant leukocytosis, inflammatory markers were raised, autoimmune panel were all negative, including RA, ANA, HLA-B27. Blood culture and urinalysis was normal as well. So imaging showed X-ray with left hip with slight hedginess around lesser trochanter. USG left hip and thigh showed fluid collection in joint space and in the insertion site of iliopsoas, denoting synovitis and bursitis. Synovial fluid analysis showed translucent fluid with neutrophilic leukocytosis. Cramp stain showed no organism, and fluid were negative for crystals as well. So we came to the conclusion that the patient has arthritis, but since we couldn't find out the organism or the particular diagnosis for treatment, we started exploring infectious panels, keeping in mind the epidemiology of different diseases in this area. So the malaria, dengue, chlamydia DNA from urethral swab, HIV, hepatitis B and C, brucella, leptospira all came back negative. Scrub typhus was positive with high IgM and IgG titer. So the diagnosis was seronegative reactive monoarthritis left hip secondary to scrub typhus. So let's study something about scrub typhus. Scrub typhus is also known as the forgotten fever. The reason behind this is it was pretty prevalent during World War II, but it got disappeared and now it's prevalent in some areas of world only. Scrub typhus is a mite-borne infectious illness caused by Orencia susugamusi. It's a gram-negative coccobacillus and is antigenetically distinct from typhus group rickettsii. There are 3 strains, carp, gillium, and catto. Shigars is the only infected larval form that inoculates organisms into the skin. It's microscopic, 0.2 to 0.4 m in size, and the bug is the both vector and reservoir for the disease. Humans are accidental host. There is no man-to-man transmission. This is a picture of a shigar mite. This is how the pathogen looks under a microscope, and this is the picture of an S chart that is commonly presented in scrub typhus. This is the life cycle of the bug. It mostly feeds on small mammals and ground-feeding birds. Humans are accidental host, and adult and nymph forms are freely living in soil, and the transmission is transovarial, that is from adult to egg. So Orencia susugamusi stimulates phagocytosis, but then escapes phagosomes and migrates to other cells, replicating in the cytoplasm, and then it births the cell where it's replicating and migrates to another cell, and so on. When sugars inoculate Orencia susugamusi pathogens, bacteria start multiplying at the inoculation site, forming a papule first. The papule proliferate and necrotize, forming eschars with black crust, associated with some regional lymphadenopathy, which can convert to generalized as well. Scrub typhus is mainly a vasculitis of small vessels involving endothelium. Here's a fun fact. Susugamushi is a Japanese word. Susuga means something small and dangerous. Musi means creature. So it's a small and dangerous creature. This is a Susugamushi triangle. It depicts the prevalence of disease in different areas of world. one age being South Asia up to Pakistan and Afghanistan, while the other age are Northern Australia and Japan and Russia. 1 million cases of scrub typhus occurs annually. So the classic case description is presence of SCHAR, which is found in 50% of patients at bite site. Outpatient didn't have SCHAR during the presentation and even during the whole treatment hospital course as well. It's a painless papule that forms SCHAR with black crust with subsequent necrosis. It also presents with regional lymphadenopathy and transient maculopapular rash. As we see in the other rickettsial disease, the typical maculopapular rash that starts with the wrist and then spreads to both ways, it's not pretty much common in the scrub typhus. Rather, it appears in only less than 40% of patients on 4 to 6 days of illness. It's a non-pruritic macular, then papular. It can rarely be petechial as well. It is present mostly in abdomen. It can then spread to extremities. Sometimes face can be involved as well. Course of illness vary from mild and self-limiting to fatal one. Incubation period is 6 to 21 days. Patient mainly presents with high-grade fever. Subacute course can be in untreated patients. Other symptoms are myalgia, arthralgia. Some can present with severe headache, profuse sweating, conjunctival injections. So it can present very similarly to dengue fever. Other signs are relative bradycardia, lymphadenopathy, hepatomegaly, and splenomegaly as well. So scrub typhus can present from vague systemic illness to fatal complications on presentation like meningoencephalitis. Patient can also present atypically, like in our case, with monoarthritis or polyarthritis or even Still's disease. Other neurological manifestations can be facial and extremity weakness. Pulmonary presentations can be most commonly pneumonia. ARDS is a common cause of mortality. The pathophysiology behind this is unknown, but it's supposed to be diffuse alveolar damage without the evidence of vasculitis. Other manifestation can be myocarditis and rhabdomyolysis. Death can occur mostly in second week of the disease due to complications like acute kidney injury, ARDS, congestive heart failure, septic shock, multi-organ failure. In pregnant patient, it can result in spontaneous abortion as well. Case fatality ratio is 7%. Surprisingly, HIV-infected scrub typhus has minimal symptoms and good prognosis. Lab findings could be leukocytosis or leukopenia. Transaminitis is present in 60% of patients with hyperbilirubinemia and increased creatinine. It can rarely concomitantly present with thrombocytopenia as well. The most common radiological finding is bilateral reticular opacities and cardiomegaly in chest X-ray. If patient has meningoencephalitis, CSF finding will be predominant mononuclear pleocytosis. Confirmatory diagnosis is by serological assays, indirect fluorescent antibody, indirect immunoperoxidase, and enzyme immunoassays as well. PCR amplification can be also done of Orencia gene from SCHAR, lymph nodes, and blood. There's a specific gene called 56kDa protein encoding gene specifically for Orencia sugamose. Well Felix test is no longer advised. Biopsy of SCHAR is not done, but if done, it can show focal necrosis surrounded by zone of intense vasculitis with collection of lymphocytes and macrophages. Treatment is doxycycline, 100 mg BD for 7 to 14 days, depending on the presentation and the systemic involvement. In pregnant patient, azithromycin is used. In doxycycline-resistant patient, especially in scrub typhus meningitis, rifampin is used as it has good CNS penetration. Alternatives are ciprofloxacin and chloramphenicol. Our response to treatment is very good, even in complicated patients. Patients can be well within a week, so it has good response. Prophylaxis is the same, doxycycline or chloramphenicol in endemic areas, and there is no vaccine available. So other differential diagnosis could be other tropical diseases which are present in the endemic area. Malaria, dengue, brucellosis, leptospirosis, chikungunya, and typhoid fever. These are my references. And yeah, that's it. Thank you for listening, and let me know if you guys have any questions for me.
Ashriya, we have wonderful feedback in the audience as well. And thank you for not only sharing the case with us, but also teaching it to us today. And I cannot even pronounce the disease. It's very hard to pronounce it, and you covered everything for us. So very grateful for that. If you guys don't have any questions, maybe we can wrap up the session. And I was wondering if Dr. Ravi is in a place to unmute and give some feedback, but I think he was busy with some interviews. Thank you, friends, for joining us, and have a wonderful rest of your day. And goodbye, everyone.